Hey everyone, welcome to another Explainer. Today we're diving into the pharmacology of elimination. The source material frames the human body's gastrointestinal and urinary systems as this incredibly complex, highly regulated plumbing network. And sometimes the pipes get blocked, sometimes there are leaks, and sometimes the drain itself just needs fixing. So today we're going to figure out exactly which tools, or rather which medications, are used to fix our biological plumbing.
But let's just address the elephant in the room right away. How on earth do you memorize dozens of elimination drugs for your exams? If you're staring down nursing boards or pharmacology finals, the sheer overwhelming volume of drug classifications, mechanisms of action, and specific side effects you're expected to know, well, it can feel totally impossible to tackle. But don't worry, that is exactly why we're here. Let's explore how to break this all down logically and visually based on the text.
Here's our game plan for this explainer. First up, unblocking the pipes with laxatives. Second, stopping leaks with antidiarrheals. Third, fixing the drain with urinary drugs. And finally, we'll wrap up with some really easy memory tricks.
All right, let's jump right into part one, unblocking the pipes, laxatives. Now, before we start throwing around drug names, we really need to understand the fundamental mechanical action we're either trying to stimulate or slow down. That action is peristalsis. It's the involuntary constriction and relaxation of the muscles of the intestine. It creates these wave-like movements that physically push the contents forward. Basically, every single drug we discuss in our GI sections is just trying to hack this wave. So let's look at the heavy hitters first, the more aggressive, active laxatives. First, we have osmotic laxatives, like milk of magnesia or golightly. Their specific job is to actively pull water into the colon, which increases the stool volume and softens it up. Next, we've got stimulant or contact laxatives, like X-Lax. These don't just use water. They actively irritate the intestinal wall to forcefully trigger that peristalsis wave, usually getting things moving in about 6 to 12 hours. And finally, bulk-forming laxatives, like Metamucil. These absorb water directly into the intestine, plumping up or increasing the stool bulk, which in turn stimulates peristalsis. Notice how all three of these take a very active, almost aggressive approach to forcing the pipes clear.
Okay, now let's look at some softer approaches. If those previous drugs were about forcing movement, these are all about easing it. Emollient laxatives, which you probably know as stool softeners like Colace, don't actively force peristalsis at all. They literally just soften the stool and lubricate the intestine for easier elimination. Then we have chloride channel activators like Amitsa. These increase intestinal fluid secretion to specifically treat idiopathic constipation. It's a much more subtle, targeted mechanism compared to our stimulants.
Moving right along to part two, stopping leaks, antidiarrheals. So we're completely reversing our strategy here. Now we need to aggressively slow down that intestinal motility. Opiates and opiate-related agents like Lomotil and Imodium do exactly this. They hit the brakes on motility, increase stool bulk, and decrease abdominal cramping. For severe diarrhea, we have to step it up to somatostatin analogs like octreotide, which actually work by reducing intestinal secretions. Then we've got adsorbents like chiopectate, which simply coat the gastrointestinal tract to calm things down. And finally, sometimes the issue is just an imbalance, which is where probiotics like lactobacillus come in to restore your normal intestinal flora. This is a super common fix for travelers' diarrhea.
All right, let's shift gears and head downward for part three, fixing the drain. Urinary drugs.
The source material actually breaks down how we tackle bladder issues from three totally different angles. It's pretty interesting. First, urinary antiseptics, like macrodantin. These don't actually kill active infections. Rather, they prevent recurrent UTIs by limiting bacterial growth in the bladder. Second, urinary analgesics, like pyridium. These don't fight bacteria at all. They just coat the urinary tract to relieve that severe pain and burning you get with a UTI. And third, if there is an active infection, you're going to need antibiotics, which obviously vary depending on the bacteria, to actually eliminate the infecting agent instead of just masking the symptoms.
Now here's where you really need to pay attention, especially for exams. You have to know the clinical red flags associated with these drugs. If you're administering macrodantin, you must tell the patient, do not crush or chew it, and avoid taking it with milk or antacids. And for pyridium, our pain reliever, you absolutely must warn the patient that it's going to turn their urine brownish-orange and it might permanently stain their clothing. Seriously, if you don't warn them, they will panic and think they are going into acute liver failure.
Check out how these two diametrically opposed bladder problems get solved. On one side, we have urinary stimulants like bothanicol. You use this when a patient has a neurogenic bladder or nerve injuries and they have really poor bladder emptying.
They literally need help to start the stream, so the drug stimulates urination and increases bladder tone. On the flip side, we have the exact opposite, urinary antispasmodics like ditropan. You use this when the bladder is spasming out of control and causing intense urgency. It relaxes the bladder to reduce those spasms. Opposite problems, opposite pharmacological actions.
Building on that idea of an overactive bladder, we have antimuscarinics, specifically drugs like Detrol and NCLEX. These are prescribed to decrease urinary frequency and urgency in patients with overactive bladder or OAB. But look out for that massive clinical warning. Do not give these to patients with glaucoma. The mechanism of these drugs can dangerously worsen their condition. Definitely remember this, it is highly, highly testable material. Okay, we've covered the what and the how. Now for part 4, easy memory tricks, your retention cheat codes. First up, antiseptics equal prevention. Simple as that. They do not cure an active UTI, they prevent recurrent ones by limiting growth. Antiseptic equals prevent.
Next, look at the strong visual color association here. Analgesics provide pain relief. When you think analgesic, think pyridium. And when you hear pyridium, you should instantly think P turns orange. That visual will absolutely anchor the memory for you. Pyridium equals orange P.
All right, how about urinary stimulants? Just remember the S's. Stimulants help start the stream. This is exactly what you need when you have a poorly functioning or neurogenic bladder that just won't empty on its own. Stimulant equals start.
Now, what about the antispasmodics? How in the world do you remember what ditropan does? Well, look right in the middle of the word. See that A? Link that A sound directly to A spasms. Ditropan treats bladder spasms.
We can do the exact same thing for antimuscarinics. Take the drug name Detrol. See that nice prominent O right in the middle? Connect that O perfectly to its indication, overactive bladder. Detrol treats the frequency and urgency of an overactive bladder.
And listen, we have to reinforce this absolute contraindication one last time because it is literally an all-time favorite question on nursing and pharmacology boards. Antimuscarinics plus glaucoma equals an absolute no. It will worsen the glaucoma, never do it.
To wrap up this explainer, I want to throw a quick challenge your way just to test your immediate recall of what we literally just covered. So we know ditropan is an antispasmodic, but what are the classic anticholinergic side effects of taking a drug like ditropan? Do you remember the little rhyme? If you were thinking, can't see, can't poop, can't spit, you nailed it. These drugs dry you out, causing blurred vision, constipation, and dry mouth. So there you go. You now have the visual maps to actually conquer the pharmacology of elimination. But this leaves us with a pretty critical question. If these drugs can essentially stop our body's natural fluid responses, what on earth happens when they accidentally interact with the cardiovascular medications that are keeping a patient's heart pumping? Well, that's a puzzle for our next explainer.